السلام عليكم ورحمة الله وبركاته. I am Dr. Sultan Asali. I am internal medicine senior registrar. I have this presentation of diabetes mellitus and I want to share it with you. First, simply diabetes mellitus is hyperglycemia results from abnormal carbohydrate metabolism secondary to insulin deficiency, peripheral resistance to insulin action, or combination of both. Who to screen for diabetes mellitus? According to ADA 2018, all adults more than 45 years and older, patient planning for pregnancy if she has overweight or additional risk factors, and patient who is taking glucocorticoid, thiazides, diuretics, HIV medication, and antipsychotics, because all these medication increase the RBS level. And we have to screen adults with BMI more than 25 and additional risk factor, first degree relative with diabetes, and hypertensive patient, and patient with hyperlipidemia, and pre-diabetes patient. Screening intervals. Rescreen every 3 years if results are normal. This regarding to previous slide. Yearly testing recommended if pre-diabetes is diagnosed. Screening for type 1 diabetes is not recommended. The ADA recommends standard screening for any pregnant woman with diabetes risk factor at the initial prenatal visit, and if it's normal, we repeat it at 24 weeks to 28 weeks. Diagnostic criteria for DM. First, random plasma glucose more than 200, fasting plasma glucose more than 126, and OGTT more than 200, and HbA1c more than 6.5. Factor that affects HbA1c. Remember, iron deficiency anemia and kidney disease increases the HbA1c, and like blood loss, liver disease and pregnancy, all of these decrease. Always they ask about these things in MCQs. Most sensitive method in diagnosis of DM is OGTT. An abnormal result in a symptomatic person should be confirmed with repeating testing. Patient with abnormal result and symptomatic, it's enough for diagnosis. If there are two results, one of them normal and the other abnormal, remember, repeat the abnormal one. Pre-diabetes management. Pre-diabetes management prevent or delay the onset of type 2 diabetes mellitus. First, diet and exercise, and smoking cessation, and bariatric surgery and metformin. Of course, diet and exercise, most effective of them, and it delay the onset by 10 to 20 years. The ADA and the American Association of Clinical Endocrinologists recommend metformin initially for diabetes risk prevention in individuals with pre-diabetes. Really, in clinic, I give metformin for pre-diabetes patient. Management in diabetes 1 and 2. First, education of the patient. This is the most common wrong behavior we do. We don't educate the patient. Patient doesn't know about the diabetes itself and what is the lifestyle, what's the comorbidity, what is the complication, how he take the medication, how he follow up, and diet and physical examination. If the patient is very obese, we can use metabolic surgery. What is the glycemic goal for adult with diabetes mellitus? Remember, healthy patient, we have strict glycemic control, less than 7 and less than 6.5. Remember, if the patient is early in the diagnosis and the patient is healthy, we can use this tight glycemic control. If the patient has multiple comorbidity, we increase the glycemic control. Remember, pre-prandial for healthy patient from 80 to 130, and postprandial must be less than 180. Pregnant women, we don't depend on the HbA1c. We depend on the fasting and postprandial. Remember, fasting less than 95 and postprandial 1 hour less than 140 and 2 hour less than 120. The American College of Physicians recommend hemoglobin A1c between 7 and 8. But remember, also healthy patient may use tight glycemic control. When the hemoglobin A1c is not at a goal despite meeting preprandial glucose goals and fasting RBS all within normal and HbA1c high, what we do, we have to do postprandial glucose value to check if it's controlled or not. As I said before, pharmacological therapy should be individualized on the patient age, patient health status, weight, and comorbidities. Type 1 diabetes treatment, only we use insulin. Insulin dosing 0.4 to 1 international units per kg, and we divide it by 50% for basal insulin and 50% for prandial. One common question: what's the corrected pre-meal insulin? How we calculate it? We calculated each increase by 50 above the 120 milligram per deciliter equal 1 unit. We have 3 insulin types: rapid acting and long acting and mix. This table about the onset and the peak and the duration. DM type 2 treatment. What are the hypoglycemic agents? This table summarizes some hypoglycemic agents. First, insulin. What's important about insulin? What's the effect on weight? It increases the weight. And what is the disadvantage? It causes hypoglycemia. The main 2 drugs that cause hypoglycemia are insulin and sulfonylureas. And both of them increase the weight. Metformin, it decreases the weight, or it's neutral. And what's the disadvantage of this medication is diarrhea and abdominal discomfort and vitamin B12 deficiency. And it's contraindicated in kidney and cardiac failure. We have here bioglutazone and rosiglutazone. Remember the effect on the weight, it increases the weight. And remember, fluid retention, heart failure, and bioglutazone increase the risk of bladder cancer. Always about any medication, remember the weight effect and the disadvantage, because these common places for MCQs. And what about the GLP-1 receptor agonist? It causes pancreatitis and medullary thyroid tumors. We have here DPP-4 and 6-gliptin is an example of DPP-4. It can cause pancreatitis, and remember, it increases the heart failure hospitalization. So it's contraindicated in heart failure. Remember the weight effects, it can decrease the weight. And we have SGLT2 like empagliflozin. It can cause acute kidney injury. It can cause euglycemic DKA. This is common MCQ. And urinary tract infection. This is also common MCQ. Remember, SGLT2 is the pest that decreases the cardiovascular disease. If hemoglobin A1C level is 9 or higher at the time of diagnosis or after 3 months of metformin therapy, the ADA recommend adding another hypoglycemic agent. The ADA recommend advancement to triple therapy. If dual therapy fails to meet the glycemic goal after 3 months. And if the HbA1c more than 9, we start insulin. So we have two options here. If the hemoglobin A1c not controlled and it's above 9, we start triple therapy or we start insulin. But in insulin, we stop another agents and continue the patient on metformin. Glycemic control should be assessed every 3 months with subsequent adjustment to the therapeutic agent until the glycemic target is achieved. If the glycemic target is achieved, we check every 6 months. Remember these points about metformin. It causes gastrointestinal effect, so we titrate the dose of metformin. Metformin contraindicated if EGFR less than 30. If an iodinated contrast agent is administered with an EGFR between 30 and 60, we have to stop metformin for 48 hours. We have to stop metformin if the patient has any dehydration or vomiting or diarrhea, and long-term metformin use may result in vitamin B12 deficiency, and annual vitamin B12 level testing is recommended. And now we will talk about the insulin in type 2 diabetes mellitus. First, basal insulin. We have two options: starting dose at 10 international units per day or 0.1 to 0.2 unit per kg per day. And we check if the patient has hyperglycemia, we increase 2 units, and if the patient has hypoglycemia, we decrease by 4 units. And the basal insulin cover the fasting and pre-meal RBS. What about the prandial insulin? We initiate prandial insulin at largest meal starting dose 4 units or 10% of the basal dose. And if the patient has hyperglycemia or hypoglycemia postprandial, we change the dose. Regarding hyperglycemia, we increase it by 2, and also for hypoglycemia, we decrease it by 4. Inpatient management of hyperglycemia. Tight inpatient glycemic control from 80 to 110 is not associated with improved outcome and may increase the mortality. Don't continue the oral or non-insulin agents. When you start insulin, if the RB is more than 180 and to target 140 to 180. Don't select sliding scale. It is not recommended since it's a reactive, non-physiological approach that lead to large glucose changes. And inpatient management for the patient who is eating is basal insulin and prandial insulin. And thank you. This is regarding my presentation. If you have any question, please ask me in Twitter in the comment. And I have this multiple questions. I hope you read it and give me the answer in the comments. and thank you.